for the nice introduction. It's an honor, absolute honor to be at this forum and discuss the echocardiography overall, mostly the transesophageal in the liver transplant patients. I do not have any disclosures. The most of the cases I will show you are the transplant cases at our institution, with few examples from our cardiothoracic patients because they were very relevant. So what are the indications of using a transesophageal echocardiography in a liver transplant patients? We all know that it's been widely used in the cardiothoracic procedures, and the usage is now increasing in the non-cardiothoracic general operating room side, and there's a lot of interest to use it because in the liver transplant patients, because of the severe hemodynamic compromise, as well as the physiological changes, and for the purpose of intraoperative monitoring of the cardiac structure. Particularly the echocardiogram helps us visualize the cardiac structures and function in real time. So, and all the American Association for the Study of the Liver Disease highly recommend using TEE during the transplant patients because it gives us an idea about the ventricular functions, hypertrophy, diastolic function, valvular function, and outflow tract obstructions. I will show you some of the cases pertaining to all these topics. So what is the current practice in United States? In 2010, the American Society of Anesthesiologists conducted a survey, and according to the survey, half of the members and experts agreed that the TE should be used in the liver transplant patients. A recently published article mentioned that in high volume transplant centers, the frequency of using TEE for liver transplant patient is approximately like 94%. Maybe one of the reasons is the availability of trained staff, more familiarity with using the TEE during the transplant procedures in the high volume centers. The question comes in mind, is it safe, particularly with liver transplant patients mostly have varices and esophageal bleeds. Is it safe to do a TEE in transplant patients? The overall complication reported is quite low, is 0.02 to 1% approximate. Different studies have mentioned different percentages for that. As I mentioned, the most important two reasons comes in mind when we talk about liver transplant patients is esophageal injury and the varices. The reported complication in one of the studies in liver transplant is 1.7%. There are certain things we can do to reduce the risk with the TEE. We can reduce the size of the probe. At our institution, we have pediatric probes available in case if we have difficulty in placing the adult probe in. We should avoid too much manipulation and reduce the length of the time the TE probe is in the place. These are some of the techniques can be used to decrease the chances of having any side effect for that. The ASE and SCA put down some complications, and a few things interesting to note in this table. The incidence of complication with the TEE is higher in diagnostic overall complications as compared to intraoperative TEE monitoring. Is about 2.8% in diagnostic and 0.2% in intraoperative. Maybe one of the reason is the patient does not move and patient is relaxed intraoperatively, and it's the circumstances are easy to perform the TEE during the procedure. But another interesting thing to note here is the esophageal perforation. The incidence in diagnostic is less than 0.01, but is higher intraoperatively, it's about 0.3%. Again, the same reason, patient does not give us a feedback because patient is under anesthesia and relaxed. So that's why it's very important for us to be careful if there's a resistance or there is any complication. We should not fight with the resistance and be very careful in placing the TE probe in these patients. The other complications can be heart failure, arrhythmias, tracheal intubation, endotracheal intubation, malposition, laryngospasm, bronchospasm, dysphagia, minor bleeding from the pharynx, severe rhinophagia afterwards, hoarseness, lip injury, and dental injury. There are certain contraindications. As in, we're talking about the liver transplant patients, the question comes in mind, is it safe to place a TE probe in varices? According to the SCA and ASC guidelines, it is not an absolute contraindication. If the patient has varices, the absolute contraindications are a perforated viscus, most likely the stomach and the esophagus, strictures, tumors, perforation or laceration in the esophagus or diverticulum, and if the patient has an active upper GI bleed. If a patient have a recent upper GI bleed also is a relative indication, not a contraindication, not an absolute contraindication. As far as the esophageal varices are concerned, as we know, there are three grades of varices. We should be really careful in grade third variceal. A patient with grade three varices and should not manipulate too much in the stomach. Avoid the transgastric views for that. So in the anhepatic phase, when the IVC is clamped, the varices becomes more engorged. Particularly in that period of liver transplant, manipulation of the TE should be avoided to avoid any kind of injury to the varices. And as we discussed, grade 3 varices, avoid deep transgastric and transgastric views. Um, Dalia et al. Recently published a nice review article on this topic, and I like this flow diagram according to them. So if there is a TE or transthoracic echo is done in the last 6 months, review the review for high risk intraoperative conditions. And this can be LV-RV dysfunction, PFOs, tricuspid, mitral regurgitation, and the patient at the risk of SAM or outflow tract obstruction. We will look at all these conditions a little bit in more detail in the later slides. If none of these are available, you should have a TE available, but you don't have to place a TE in. If any of these conditions or some of these are available, then just look at the patient. If the patient has then grade 3 varices or upper GI bleed, if yes, have the TE available to be utilized because of it's extremely useful in life-threatening conditions in hemodynamic instability. If not, then you can place the TE. If the echo is not done in the preoperative, which is quite rare actually, in preoperative preparation, it's very common to have an echo. But if it is not done for some reason and the patient does not have any of the risk factors, place a TE. If there are risk factors, do a transthoracic first. And if the risk factors are present, place the TE, otherwise have the TE available. So in the preoperative evaluation, it's very important to look at the baseline functions and any particular risk factors which can affect the intraoperative course of the liver transplant. One of the example is like hepatopulmonary syndrome. That's important to know beforehand. Cirrhotic cardiomyopathy. Dr. Hackel has discussed a little bit about this yesterday. 28% of the patient coming for liver transplant have some valvular pathology, and 27% have coronary artery disease baseline, and about 10% have pulmonary hypertension. So these are some of the conditions, the cardiac conditions we should look at in the preoperative echo, biventricular functions, valvular pathologies, patent foramen ovale, pulmonary hypertension, effusions with or without tamponade, pleural effusions, septal hypertrophy because it increases the risk of outflow tract obstruction and diastolic dysfunction. So I'm going to show you a slide about the hepatopulmonary syndrome, and we'll show you an example. How does it look like? As we all know, the hepatopulmonary syndrome basically the dilatation of the vessels inside the lungs causes diffusion defects as well as neovascularization inside the lung. So even in the absence of intracardiac shunting, there is right to left shunting in the liver patients, and the chances of paradoxical embolus, air embolus, or clot embolus is higher in the presence of hepatopulmonary syndrome. So these are some of the transthoracic images. And just to orient ourselves, this is the right atrium, right ventricle, left atrium, left ventricle. Apex is here. This is transapical view. And agitated saline is being injected in the right side. And you will see there is no intracardiac shunt, but you will see the appearance of the agitated saline, which should not appear actually in normal people. In about 4 to 6 cardiac cycle is appearing on the left side. This is, if you see this in a preoperative transthoracic echo, this is a sign the patient has a hepatopulmonary and right to left shunt. The same patient, we requested the patient to have Valsalva, which is the expiration against a closed glottis to increase the intrathoracic pressure. In spite of increasing intrathoracic pressure, there is appearance of the agitated saline on the right side. Why do we request the patients to have Valsalva? Just to clarify that, to increase the pressure on the right side of the heart. So if there is any intracardiac connection, it becomes more evident. So compare this transpulmonary shunting. This is a patient who has intracardiac shunt. I have some more echo pictures of the same patient. You see, like here, right after injection of the saline, because of an ASD present in the contrast, this agitated saline contrast moves to the left side. So presence of patent foramen ovale is important to know during the transplant patients. Why? Because the physiological changes happen, and the pressure on the right side can increase during the transplant patients, and this left to right shunt can go into right to left shunt and can cause paradoxical embolus. How can we know if there's a PFO present? With the transesophageal echocardiogram, you can see about like 90 to 110 mid-esophageal view. You can nicely see the intraatrial septum. There's a left atrium here, right atrium here, SVC and IVC. There are a few examples I would like you to concentrate on. Here in this one, there is a lot of color noise. And if you decrease your coloring scale, you won't be able to find a PFO even if it is present. So here in this example, same patient and we cannot see any PFO. So we decrease it down to about 60, and we can see there is something present. But the recommendation is, because it's a low flow connection, the 30 on the color scale is the recommended scale to find a PFO. So on 30 is very evident. It's a left to right shunt. So the same patient post-operatively, by some reason, because of hypoxia or clot formation, or has acute increase in the right-sided pressures, and open up the PFO into an ASD. This patient become hypoxic post-operatively, and now the shunt is reversed. It's from right to left. And doing a bedside echo, transesophageal echo, we were able to find it, and we took the patient to cath lab, placed an Implanter device, and with the dramatic increase in the saturations, and patient did well after that. Also, we can find the pulmonary hypertension by calculating the right ventricular systolic pressures. When the right ventricle is in systole, the pulmonary valve is open, so the pressure in the right ventricle is equivalent to the systolic pressure in the PA. And if we have tricuspid regurg, placing continuous wave Doppler through it, finding the peak tricuspid regurg velocity, and adding CVP into that will give us a right ventricular systolic pressure, which is equivalent to the PA pressure. This is an example how to do it. So here we see there's about moderate size of tricuspid regurg present. We put a continuous wave Doppler through it, find the pressure gradient, because the flow goes back. It's the difference between the pressure in this chamber versus the RA chamber. The pressure in the RA chamber, we all know, is a CVP. So adding that pressure into the pressure gradient will give us right ventricular systolic pressure and PA systolic pressure. So diastolic dysfunction is another important topic in the transplant patients. Most of these patients does have some diastolic dysfunction. It's important to know because the hemodynamic changes during the procedure can present differently in patients with diastolic dysfunction. And maybe sometimes a lusiotropic medication is more helpful than inotropic medication in those patients. So these are few examples of the diastolic dysfunction. There are basically 3 grades. The first grade is impaired relaxation, the second is pseudonormal, and the third and the final grade is restrictive. Basically, the patient starts with grade 1, and in most severe cases goes to grade 3. Just to discuss, just to spend a few more seconds on this topic, place a pulse wave Doppler right on the mitral valve leaflets. That gives us E and A waveforms. The E waveform stands for early filling of the ventricle. So when the mitral valve opens, most of the flow from the left atrium into the left ventricle happens during that phase of diastole. So it's E stands for early filling of the left ventricle. And then the atrial kick sends the rest of the blood from atria into the ventricle. So normally the E to A ratio should be, so E should be always be bigger than A. The second important thing to do in these patients is to do a tissue Doppler by putting a pulse wave on the lateral aspect of the left ventricle, lateral wall of the left ventricle. That gives us E prime. Just to remember that your probe is right here, so any movement towards the probe will give you a positive deflection. So if the heart is moving nicely, you're going to have a nice waveform, and the E prime will be more than 10 centimeters per second, which is considered normal. The machine also gives you E to E prime ratio, and that will be less than 8 because both movements are normal. If there is impaired relaxation, the heart is not relaxing and not letting the blood come in the early diastole. So the atria has to do most of the work. So this ratio reverses. Not a lot of, and here also you can see the E gas goes down because the movement of the lateral wall of the ventricle going back to the probe is slow now. Gradually, the pressure in the left atrium increases. And with the increase in pressure, it started pushing more blood back. And this stage is called pseudo-normalization because though it looks pretty much same as the normal EA, but in fact, the E to E prime is now higher because E is higher and E prime is lower because of the decreased movement of the lateral wall of the left ventricle. And the final stage is when the left ventricle is quite have a severe diastolic dysfunction. The E is way higher as compared to A. And then you will see the E to A prime ratio of more than 13. The strain is another topic, which is very kind of like in focus currently, especially in the diagnosis of cirrhotic cardiomyopathy. Just to discuss a little bit of cirrhotic cardiomyopathy, these patients have normal looking hearts in liver cirrhosis, but in conditions when there is a strain on the heart, they fail. Um, there is a lot of research going on that. I'm going to show you two examples of strain. This is a relatively normal strain, and this is a really bad function of the heart. How to look at those? It's easy to do on the new machines. You just have to point 1, 2, and 3, means like the base of the ventricle and the apex in 3 views, and it will give you the strain. How we read it, any negative number more negative than -16 is better. So, and just to make it easy, there's a color coding on this side. The dark red is negative, -20, and the blue is 20. This bullseye is time to peak. So a slower heart it does take more time to start contracting as compared to a normal heart. And if you compare this bullseye as compared to this bullseye, and you can clearly see that almost all the left ventricle taking its time to move after only a little bit of kind of segments of the base are moving. There's a lot of research going on this, and we still are waiting for some guidelines, but this is a good thing to do in the liver transplant patients. So let's move on to the intraoperative phases, the pre and hepatic phase, where the surgeons are dissecting. There's a really good time to do a baseline intraoperative TEE and to evaluate the normal functioning of the heart and the valves. This is an example of the normal volume and a normal ventricle. Mid-esophageal 4-chamber view, you can see both right ventricle, left ventricle moving nicely, bi-chamber, anterior and the inferior walls of the left ventricle moving nicely. There's a long axis aortic valve, LVOT. You can see there is no alveopseptal hypertrophy or any kind of risk factor for the SAM. Transgastric views, mid-pap view, where you can see the papillary anterolateral and the posteromedial papillary muscles, as well as the long axis view. So this is a normal patient. Most of the cirrhotic patients are hyperdynamic. So this is an example of a hyperdynamicity in a cirrhotic patient. You can see that the heart is a little more aggressive. Um, and this is a transgastric view, and you can see that it's a hyperdynamic left ventricle. Also in the in anhepatic phase, if venous bypass is being used, sometimes the surgeons placed a cannula through the SVC. The T is extremely helpful in guiding the placement of the cannula. We don't use venous bypass in our center that much, but we do have a left subclavian central line just in case if we need to. But this is an example of a venous cannula coming from the SVC. Also, these cirrhotic patients have ascites. So after the abdominal incision, the ascites drain and cause hypovolemia of the liver. This is a patient, you can see the ascites as well as the cirrhotic liver and hyperdynamic hypovolemic heart. So with the incision, the ascites drains and a patient can develop hypovolemia, and the T can help you guide the volume therapy in that condition. Ejection fraction is another, there are two ways we can do the ejection fraction, subjective and objective. Subjective is with the experienced eye, you can see and you can designate a number like a patient, it's a normal ejection fraction, slightly decreased or decreased, or you can do some objective measures. So objective measures is easy to do with the newer machines. There's the quite popular method is Simpson's method of disc. Why it's popular? Because as you can see, the software in the machine will calculate the ejection fraction at different levels, not at like one single level, and we'll see the movement in diastole and systole at almost globally in all the left ventricle. Easy to do. Once you hit the button of MOD EF calculation on the machine, you just have to point out 3 anchoring points, the base of the left ventricle and the apex, and the machine does the rest of the work. You can also move the points according to if you are not happy with what the machine is tracing, and it will give you the ejection fraction. Another fast method of doing ejection fraction calculation is fractional shortening, but the problem with this method is it will give you the ejection fraction only at one level, which is the mid-pap level most of the time, as compared with the method or disc. How to do it? You can go to transgastric and you place a M mode, and then you do left ventricular and then you do the left ventricular diastolic diameter and then systolic diameter, and the machine will calculate the EF for you. The newer softwares does have 2D quantification method. Again, on the same principle of method of disc. So I'm just going to move forward with that. You can also calculate cardiac output and stroke volume is by placing a pulse wave Doppler in the LVOT or in the RVOT, and calculating the size of the RVOT will give us the cardiac output. So during the anhepatic phase, there is complete clamping of the portal venous system. Hypovolemia also can be piggybacked. RV and LV dysfunction can happen during this phase. This is an example of RV dysfunction. And this is an example of regional wall motion abnormality. The inferior wall is not moving. I'll be a little faster. I think I do not have much time. There are some interesting cases I would like to show. This is an example of RV dysfunction, which we diagnosed with the help of the TEE. With starting the management, the RV improved. During the reperfusion phase, it's characterized by a lot of hemodynamic lability. There is delivery of the hypothermic and acidotic blood, causes vasodilation, as well as the thrombus formation. Dr. Crowley did a good job with the ECMO presentation. We use Avalon cannula. It goes from the right side SVC into the IVC and takes blood from the SVC and IVC and brings back towards the tricuspid valve. This is an example of placement of the Avalon ECMO cannula. The guide wire is going from SVC to IVC. Cannula is placed, and confirmation of the flow to the tricuspid valve. Impella is another technique in patients who have the dying left ventricle or the right ventricle. We can place the impella. This is the use of echocardiogram placement of the impella. Guide wire is going through the aortic valve. passed through the aortic valve, impella is placed and confirmed with the echo going into the cannula and coming out into the aorta. Thrombus formation is important to diagnose during the transplant patients. This is an example of thrombus is forming, the right-sided dysfunction. Tricuspid regurg happen. We can see like a thrombus is forming with a 3D, and it's also going into the pulmonary artery. And when you diagnose this, it's important to start some treatment for that. Another example of intrathoracic thrombus. And last one, this patient has thrombus formation also. This is one of the transplant patients, and we worked accordingly. Like, we did not reverse a little bit of coagulopathy completely in this patient, and this patient did really well afterwards. And the right to left shunt can cause the air and the embolus to go to the left side and can cause a stroke or a paradoxical embolus. This is some air entering from the left side into the aorta. This is the right coronary artery, and you can see the air entering to the right coronary artery, giving us some ST segment elevation. When you see this, the treatment basically is to increase the pressure, and that will help in that condition. Systolic outflow tract obstruction is another condition, can happen in high-risk transplant patients. This is one of our transplant patients who was being coded. Actually, we put the TE probe in, and we found that the patient has a systolic anterior obstruction of the LVOT, and then we started treatment according to that. That obstruction opened up, and the patient did well with open flow to the aorta. Takotsubo cardiomyopathy in the previous talk has been discussed. The incidence is about 1.4%. This is the Takotsubo is called because of the pot, the Japanese pot for the squid trapment. The base is narrowed as compared to the body. This is one of the transplant patient post-operatively hemodynamically unstable. We did a transthoracic echo, and you can see a clear Takotsubo and with a 3D. We did the sportive measures 12 weeks later, the same patient, much improved left ventricle. So additional pathologies, the reperfusion can have the pericardial tamponade and pleural effusion. This is an example of pericardial tamponade pressing on the right side of the heart, and an example of the left pleural effusion. Post-liver transplant, last case for the talk. I think I'm utilizing all my time. Sorry about that. Post-transplant, also you can utilize the TEE to see the anastomosis. This is an example of a case where the surgeons found that the liver is a little more congested. We've followed the IVC, and we found there's a mismatch in the size of the IVC of the donor IVC and the recipient IVC with high flows. This is the donor IVC and the recipient IVC, and the changes in the size of the IVC. The limitations is the availability of equipment as well as the training. The Society of Transplant Advancement in the Transplant Anesthesia have a position paper published recently, and they're recommending that TE should be considered in all transplant patients, and the transplant anesthesiologist should get some training as well as the basic certification for the TE. Thank you so much.
Thank you very much, Dr. Mahboobi, for that excellent presentation. We have time for one question. Would you suggest any objective method to assess RV function intraoperatively with TEE?
So there are no software available currently. There was one slide in my talk, which I utilized the same software 2DQ for the left ventricle we apply to the right side. And that you can do. Just make sure that the machine is picking up the margins of the right ventricle correctly, and utilize the same software. But unfortunately, so far there is no separate software available for the objective RV function.
Great. Thanks again for an excellent presentation.